can be principally divided into coronal, 1/3 of the root, middle 1/3 of the root, and apical 1/3 of the root, isn't it? And if it is a multi-rooted tooth, then there can be furcation perforation. It is asking for the best prognosis. See, the prognosis would be the best whenever minimum communication with the oral cavity has occurred. Okay, because whenever there is communication with the oral cavity, oral fluids, communication with the saliva, then that site becomes infected very readily and then can lead to coagulum formation and onset inflammatory reactions. So, if we talk about coronal 1/3 and furcation region, they are most likely to be contaminated with oral fluids like gingival clavicular fluid and saliva. So they have got one of the worst prognosis. Now, if we talk about apical and the middle 1/3, they are completely encased in the bone cavity. They are not communicating with the, I would say, oral cavity. So they have got a better prognosis. Now we have to choose between middle and the apical 1/3. Then definitely apical 1/3 has a better prognosis as compared to middle 1/3. Why? Because in cases of middle 1/3 areas, if we talk about middle 1/3 perforations, okay, these middle 1/3 perforations, although they are easier to repair as compared to apical 1/3 perforations, okay, but they are more likely to interfere with the prognosis or the survival of the tooth as compared to the apical 1/3. Even if the apical 1/3 portion of the perforation does not heal significantly, the prognosis of that tooth, the survival probability of that tooth is not significantly altered. So what I am trying to say, please do not get confused with what the question is asking. It is asking you about the best possible prognosis for a tooth with perforation. Then the worst prognosis, worst, would be for the furcation and the coronal 1/3 perforations. And the best prognosis, survival of the tooth, would be for the apical 1/3. Answer would be 1. Now, best prognosis does not mean ease of repair. Okay, these are two distinctly different things. If we talk about ease of repair, the convenience or the approach, then definitely it is better with furcation and coronal 1/3 perforations. But even though we are able to successfully repair to reach the areas easily, it is no guarantee that the prognosis of tooth would be better because there is always likely to be some microscopic channels that communicate oral tissue fluid into the tooth. So, apical 1/3 is most difficult to repair, isn't it? Most difficult to repair, non-surgical repair we are talking about. Okay. The access to apical 1/3 is most difficult. But if we are able to achieve certain level of success in repairing, then the prognosis would be the best for apical 1/3. So it is apical 1/3. Answer would be 1, best prognosis. Okay, someone asked me to discuss the first question again. For the benefit of that particular student, I am coming back to the first question. What can be used for pulp protection in a tooth with an uncomplicated crown fracture involving the dentine? We all know that uncomplicated crown fracture means it is involving enamel and dentine without the pulp exposure. Now, the line of fracture is passing close to the pulp, so we have to do some sort of pulp protection. How do I know that it is passing close to the pulp? Because the question itself is asking you that what is the agent of choice for pulp protection? So the question of pulp protection comes only when the remaining dentine thickness is suboptimal. What is optimal remaining dentine thickness? It is 2 mm. Whenever 2 mm of remaining dentine thickness is present, we do not require any form of pulpal protection or medication. So if we look at the options, dentine bonding agents, they are ruled out. They are chemical composition wise, they are irritant to the pulp. They cannot be pulp protective. Secondly, they have got no physical strength to serve as a barrier for pulp protection. Light cured GIC can be used in certain situations when the remaining dentine thickness is suboptimal but more than 0.5 millimeters. Okay, because light cured GIC also consists of some resin monomers and acids that are likely to cause pulpal irritation. If we look at options 3 and 4, chemically cured calcium hydroxide and light cured calcium hydroxide, definitely calcium hydroxide is a better option as compared to light cured GIC. Now, out of these two, chemical and light cured calcium hydroxide, light cured calcium hydroxide is a better agent for pulp protection because it undergoes command set. The material is a single paste system and it would not set unless we show blue curing light to it. So we can easily place the material on the area of requirement and adapt it very well to the tooth preparation. So light cured calcium hydroxide would be the answer for question number 1. Going back to the sequence, I'll discussing question number 3. What is the recommended treatment of splinting? I think it should be splinting. Recommended treatment period of splinting in cases of lateral luxation. Rigid splint for 2 weeks, flexible, rigid for 4 weeks, flexible for 2 weeks. Now, this thing we have discussed in previous sessions also. Whenever we talk about splinting, you always rule out the rigid options. So we rule out option number 1 and option number 3 straightforward. Okay, rigid splinting is not done. Okay, what we are left? Flexible splint either for 2 weeks, 4 weeks or 2 weeks. So what is the answer for this? It is talking about lateral luxation. Okay, so if I talk about luxation injuries, there are 5 types of luxation injuries: concussion, subluxation, lateral luxation. Okay, the tooth has become lodged in one of the sockets, wall, mesial distal buccal lingual, extrusion of the tooth, extrusive luxation, and intrusion of the tooth. This is also the increasing order of severity of the luxation injury, increasing order of severity. Now, concussion does not require any type of splinting because the tooth is not mobile. If I talk about subluxation, the duration of splinting is 2 weeks. That would be flexible or semi-rigid splinting. Okay. For extrusion also, the duration of splinting is 2 weeks. Again, it would be what? Semi-rigid or flexible splinting. And for lateral luxation and intrusion, you have to remember that it is 4 weeks of semi-rigid or flexible splinting. So what would be the answer over here? It would be option number 2, flexible splint for 4 weeks. Okay, you should remember these splinting durations. And what is the duration of splinting for avulsion? Avulsion is another form of injury which requires a splinting. It is 1 week, or we can say 7 to 10 days. It would also be a flexible or semi-rigid method of splinting. Okay. So in this particular question, the answer would be option number 2. Okay. Question number 4. According to what you see classification, which type describes a root with a single canal that splits into 2 canals? Okay, a single canal and it splits into 2 canals. So this configuration it is asking you. What you see is configuration. I think this is a straightforward question which all should be able to answer if you remember the what you see is 8 subtypes of canals. Okay. So 1 splitting into 2 is a configuration, 1-2 configuration. 1-2 configuration is what you see, type 5. Option 1 would be the answer, isn't it? If I summarize the what you see canal configuration again, type 1 is a 1 canal configuration. Type 2 is a 2-1 canal configuration. Type 3 is 1-1 canal configuration. Type 4 is 2 canal configuration. Type 5 is 1-2 canal configuration. That is what the question is asking. So the answer would be type 5. Type 6 is 2-1-2 configuration. Type 7 is 1-2-1-2 configuration. And type 8 finally is 3 configuration. Okay. This is what you see type 1 through type 8. And it is very important that you remember these because what you see canal configuration are one of the frequent questions asked in both your INICET and NEET PG examinations. Okay. Question number 5. Okay. Just a minute. Which of the following is correct order of zones in enamel caries? So it is asking about the histological zones in a well-established carious lesion. Which of the following is the correct order of zones in enamel caries? Dark zone, translucent zone, zone of bacterial invasion, surface zone. So if we talk about a carious lesion, this is the pulp, this is dentino-enamel junction. Okay. A pit and fissure carious lesion would be like this. A smooth surface carious lesion in enamel would be like this. Wide at the top, narrow in the bottom, and a pit and fissure carious lesion in enamel would be narrow at the top, wide at the bottom. It spreads with the DG. Now this, whether it is smooth surface or pit and fissure carious lesion, when it is seen in histomorphological sections, then this carious lesion can be divided into zones. The zone can be remembered as T, D, B, and S. T, D, B, and S. T stands for the innermost zone, that is the translucent zone. D is the decayed or the dark zone. Then the body of the lesion, and finally the surface of the lesion. Okay. The body of the lesion, surface of the lesion teamed with bacteria. Very highly porous surface of the lesion is there. The body of the lesion has a pore density. It is porous. It has got a pore density of 5 to 25%. Maximum pore density in the center, that is 25%. The porosity decreases towards the periphery, that is up to 5%. The dark zone has got nearly 1% porosity, and the translucent zone is the innermost zone. So what would be the sequence? Translucent zone, dark zone, body of the lesion, and surface layer. T, D, B, and S. You can remember like this from inside of the tooth to outside of the carious lesion. Option B would be the answer, or second option would be the answer. Okay, these are the zones of enamel caries. Question number 6. How is a widened and elongated coronal pulp chamber represented? Now, this is an interesting question, which usually you would not find in the textbooks. How is a widened and elongated coronal pulp chamber represented or is described as? Tulip shaped, dumbbell shaped, thistle tube shaped, and test tube shaped. I mean, these are the morphological appearance of elongated and widened coronal pulp chamber. So if we talk about a particular tooth, okay, like this, that has got a root, and suppose this is a tooth which has got a elongated and widened coronal pulp chamber, and then it seeps down into a fine pulp canal. Now, what shape is this? Is it tulip shaped? See, tulip are a flower which are shaped like this. Sorry. Okay. They would be shaped like this. Tulips. Okay. This is tulip shape. Okay. Dumbbell shaped. Dumbbell. Something like this. So is the pulp chamber looking like this? Tulip? No. Is the pulp chamber looking like dumbbell? No. Thistle tube and test tube. What would be the shape of a test tube? Test tube is cylindrical. Okay. Is it resemble a test tube? No. This elongated coronal chamber represents a thistle tube. Okay. So answer would be option 3. Now, if it comes into your mind, what is a thistle tube? Thistle tube is basically a lab equipment. It is a glass tube which is used for mixing different chemicals together. So basically, a glass tube, wide and elongated with a narrow outlet. Okay. And suppose this is a beaker filled with some chemical, another chemical is poured through it. So there is a reservoir and there is a drainage. This is thistle tube. So basically it is a lab equipment thistle tube. Obviously it is not required to be studied for your purpose, but just to explain you what is actually a thistle tube, I have told you that this is the chemistry lab equipment. So an elongated and widened coronal pulp chamber resembles a thistle tube in shape. An interesting question this is. Question number 7. A patient with pulp exposure has calcium hydroxide applied directly to the exposed pulp to preserve its vitality. What is this procedure called? Very simple. It is direct pulp capping. There is no need for any explanation with this. Is a very simple question. Okay. Coming over to question number 8. Which factors influence the tissue dissolving properties of sodium hypochlorite? Another interesting question. What factors influence the tissue dissolving properties of sodium hypochlorite? We know that sodium hypochlorite has a potent organic tissue solvent. In fact, it is the only known irrigant that is a tissue solvent. pH, temperature, volume, and concentration. Okay. Now, out of these, we know that increase of temperature increases efficiency of sodium hypochlorite. Heated sodium hypochlorite is a better chemical irrigant as compared to cold sodium hypochlorite. In fact, in the temperature range of 5 degrees to 60 degrees Celsius, for each 1 degree Celsius, efficacy is doubled. Okay, but it is in a particular range up to 60 degrees Celsius. For each 1 degree Celsius rise in temperature, the sodium hypochlorite's potency or efficacy is nearly doubled up to 60 degrees Celsius. So temperature is one factor that certainly influences the tissue dissolving capacity. pH of sodium hypochlorite is in the range of 9 to 11. It is a basic solution, or we would say it is an alkaline solution. Okay, so pH generally does not affect the tissue dissolving capacity of sodium hypochlorite. Volume, definitely it got increased flushing action. The primary action, the primary requirement of root canal irrigation is adequate flushing of the root canal, no matter what chemical irrigant we are using. So the primary thing is flushing. And what is meant by flushing? Greater the volume of the irrigant, greater would be the flushing of the necrotic and the infected debris from the root canal. So volume, increasing the volume of root canal irrigation definitely increases the efficacy of sodium hypochlorite. Concentration, although has got an effect, but not significant. pH would not have any effect on the tissue dissolving capacity because it remains fixed for the solution. Concentration of sodium hypochlorite ranges from 0.5 to 6% for endodontic purposes. Definitely a higher concentration would be somewhat faster in dissolving the tissue elements, but it is not significant. What are the significant factors? It is the temperature and the volume, option 2 and 3. So if we look at the options 1 and 2, no. 2 and 3, yes. 1 and 4, no. 4 and 2, no. So what would be the answer? Option number 2. Okay. Question number 9. Which factor does not influence the root canal morphology of mesiobuccal canal of a maxillary molar? Interesting. So we know that a maxillary molar is a tooth with a curved mesiobuccal canal, a straighter distobuccal canal, and a palatal canal, isn't it? So which factor does not influence the root canal morphology of this mesiobuccal root? Distance between MB1 and MB2 canal. Will it influence? Yes, it influences the root canal morphology. If we look at the tooth from above, it would be having three principal canals, that is mesiobuccal, distobuccal, and palatal like this, and this would be MB2. So the greater the distance between these MB1 and MB2 canals, the shape of the root changes to more dumbbell shaped. Okay, here they are close together, slightly wide apart, more wider apart. So the cross section or the shape of the mesiobuccal root changes with distance between MB1 and MB2 canal changes. So this factor would influence length of mesiobuccal canal. Okay, will it have any significant influence? No. The length would not affect the morphology of the root. It would be root morphology mesiobuccal root. Angulation of mesiobuccal canal definitely would influence the morphology of the root, and diameter of MB2 canal. Definitely greater the diameter, the root canal would be more bulbous. The root would be more bulbous because the canal diameter is wide, isn't it? So this would also influence. Which factor would not significantly influence? Length of the mesiobuccal canal. Option 2 would be the answer. Okay. Question number 10. In the recent ICDA's caries classification, international caries, okay, diagnosis and assessment system. ICDS, what is the full form? International caries diagnosis and assessment system. Which option correctly represents an initial lesion? Initial carious lesion. So what is there? This thing is basically done to confuse the students. If some student is not well versed with the ICDS classification, looking at it, the student can get panicky. Yeah, what is this asking about? So you just read the options calmly, and I hope that all would be able to arrive at the answer correctly. White spot lesion and black spot lesion? No. What is black spot lesion? No. Initial lesion, is always a white spot lesion, not a black spot. It is advanced lesion. So option 1 is ruled out. A white spot lesion visible after prolonged drying or cooling of the tooth. Yes. How do we distinguish a hypocalcified area with what? Your carious lesions by drying and etc. So a white spot or cavitated lesion that is visible after drying can be the answer. It can be an answer. Look at the other options. Cavitated lesion in enamel with visible dentine. No, this is not initial. This is advanced lesion. Entire enamel is cavitated and the dentine is visible, means it is not initial. The question is asking about initial. Visible enamel degradation. Okay. No. There is no break in the continuity of the enamel. No break in enamel continuity. We know that in the initial stages of the caries, there is no break in the continuity. Simply there is a white spot lesion which is there after drying of the tooth. So answer would be option 2. Okay, come over to question number 11. What is the ideal height of MTA to be placed at the apex in a root with an open apex? So it is basically asking you about the treatment of apexification. And in apexification, we do in immature pulpless teeth. The procedure that is commonly used is apexification, where an apical MTA plug is made. So this is the tooth. We make an apical MTA plug, isn't it? Apical calcific barrier is formed. So what is the ideal height? You have to remember this. It is in the range of 4 to 5 millimeters. Okay, 4 to 5 millimeters. So 3 to 5 millimeters, depending on the length of the root present. No. 5 to 7, 1 to 3 millimeter. Which is the best possible answer? Option 1 would be the best possible answer. And what is the common range? 4 to 5 millimeters. Now suppose the question is giving you two options, 4 millimeters and 5 millimeters as separate. Instead of a range, you are given options like 2, 3, 4 and 5 millimeters. Then what would be the best possible answer? 4 millimeter would be the best possible answer. So I have given you both the possible configurations of asking the questions. It can be a single figure or it can be a range. If it is talking about range, the empty apical plug is 4 to 5 millimeter thick. If a single option has to be chosen, single would be best possible 4 millimeter. Question number 12. What is the optimal treatment option for tooth 2-1 with a complicated crown fracture and open apex? So enamel, dentine and pulp exposure is there and there is an open apex of the tooth. This is a figure based question, but no radiograph is attached. It is asking you about this traumatized tooth that has gotten something. It has got open apex. Okay, and there is pulp exposure. MT in the apical region, regenerative therapy, calcium hydroxide apexification, or periapical surgery. So it basically becomes a tooth that is immature pulpless tooth, isn't it? Why pulpless? Because there is traumatic pulp exposure. The pulp has become necrotic. It is immature because the root formation is not complete. So whenever you encounter a clinical situation of immature pulpless teeth, there are two treatment modalities available. One is conventional treatment modality and another is contemporary. Conventional treatment modality is epexification, that is, we create an apical calcific barrier. Contemporary treatment modalities, regenerative endodontic procedures, REPs we do. Okay. So whenever you encounter a clinical situation in a question that is asking you for treatment of immature pulpless tooth, the first choice answer should always be contemporary, that is regenerative endodontic procedures. So if we look at the options, option 2 would be the answer. If this is not there, then conventional treatment modalities can be either calcium hydroxide epexification or MTA. If I talk about preference of treatment, then calcium hydroxide number 1 is least preferred, MTA number 2 is more preferred, and regenerative endodontic procedures, they are the most preferred treatment alternatives for your immature pulpless tooth. So always answer the questions in this sequence. Look at the options available. This is MTA epexification, this is calcium hydroxide epexification, and this is REPs. So what is the most favorable? REP, regenerative therapy. Question number 13. Which of the following is the ideal for performing obturation? Okay. When the patient is free of pain, when the canal is free of purulent discharge, once the microbial culture is sterile, when the temporary restoration is intact. Which clinical situation is best preferred for successful obturation? When the patient is free of pain, it is 50-50 chances because the patient may be having pain due to numerous factors, and we cannot wait always for the patient to be totally asymptomatic before obturation. It is definitely preferred but not ideal. When the canal is free of purulent discharge, okay, canal is free of purulent discharge means there is no, whenever we open the tooth, we see that the canal, we are able to achieve dry canals. We are able to achieve dry root canals. Okay. Whenever we are able to achieve dry root canal, it is definitely one of the best preferred clinical scenario. Okay. Once the microbial culture is sterile, okay, it is desirable. But to obtain 100% sterile microbial culture is not possible, and at times there can be false positive and false negative results from microbial culture. Okay, there can be numerous reasons for that. Currently, I'm not discussing why there can be false positive and false negative results from microbial cultures, but there are certain things called carryover effect of your root canal irrigants and medicaments. Okay, so to achieve a sterile microbial culture is desirable, but not an ideal situation for obturation. When the temporary restoration is intact is also a desirable situation. That subsequent appointment when the patient comes for obturation, the temporary restoration should be intact. That means that the no coronal seepage has occurred, desirable. So out of the 4 options, option number 2 is the best preferred option or nearly ideal situation for performing obturation of the root canal. So overall talking, all 4 are correct. But which is the best possible or ideal situation? Option 2, when we are able to obtain dry root canals. Question number 14. A patient with severe intrusive luxation was treated. Okay. When is the correct time to perform root canal treatment? We know that intrusion is the most severe form of luxation injuries. Okay. Then severe intrusion, pulp necrosis is most likely. So such patients would require RCT. Now, since severe intrusion has occurred, the first priority is always to place the tooth back into its original position and splint it. What would be the duration of splinting? It would be 4 weeks of semi-rigid or flexible splinting, as we have discussed previously. Okay. So when to perform the root canal treatment? There is no urgency to perform the root canal treatment immediately. Okay. Always remember that. Although pulp necrosis is most likely and the tooth would require subsequent RCT for survival, but it's not an urgency. What is the urgency? Urgency is always to position the tooth back into its original place and do the splinting. So at the time of splinting, no, there is no urgency to do root canal. Immediately after splint removal, it is asking splint removal. Yes, after the duration of splinting is completed, we can do root canal properly. Immediately, I have already told you there is no need, no urgency to do root canal. Only if the patient is experiencing pain, again not desirable, because I have told you that severe intrusive luxation means the pulp survival is highly unlikely. So we cannot just splint the tooth by repositioning it and wait for the symptoms to appear. It's better that once the duration of splinting is over, that is 4 weeks, are gone, we do the root canal so that the necrotic pulp is removed and there is no inflammatory external root resorption. Okay, so best answer is immediately after splint removal. This is also a very good question which requires a lot of clinical applications. Question number 15. An 18-year-old boy with a history of lateral luxation injury a decade ago presents with discolored tooth. Okay, the tooth is asymptomatic. Radiographic imaging shows pulp canal obliteration. What is the best treatment option? 10 years back, history of trauma, lateral luxation. Now, currently, there is tooth discoloration. But radiographically, obliteration of the root canal in the tooth is asymptomatic. What is the best treatment option? Vital tooth bleaching? No. Vital tooth bleaching, discolored tooth means it is a non-vital tooth. So there is no question of doing vital tooth bleaching. Veneers, wait and watch. No, already a decade has passed. Veneer can be an option. Endodontic treatment followed by non-vital bleaching. Okay, this is an option. Now, which one would you prefer? Radiographic images shows pulp canal obliteration. What is the best treatment option? Okay, it can be either option 2 or option 4. Now, which is the best option available? Although radiographic images shows pulp canal obliteration, okay, radiographically it is obliterated root canal, but it is always wise to attempt a root canal treatment, because although the pulp canal is not visible radiographically, it can be a nidus of infection to the periapical tissues, because at times the calcifications do not fall directly into the path of X-rays and they can cast a shadow. So even if the canal is not visible in the initial radiograph, it is always best to do endodontic treatment and followed by non-vital bleaching. Option 4 is greater than option 2, treatment modality. So answer would be option 4. Endodontic treatment followed by non-vital bleaching. Why non-vital bleaching? Because the tooth is non-vital, discolored. Discolored means non-vital tooth. Okay. What is the best treatment for a cracked tooth with reversible pulpitis? Reversible means pulp hyperemia. It is a case of reversible pulp hyperemia. What is the best treatment of a cracked tooth with reversible pulpitis? Composite resin restoration, full crown, double splinting, single splint. Best treatment. So there is a tooth, suppose there is a crack. Okay. So splinting is not done for cracks. Splinting is done for periodontal problems, means mobility of the tooth. Crack is a coronal phenomena. There is an incomplete fracture into the tooth. So we rule out options 3 and 4, single and double splinting. Double splinting means, what is the meaning of double splinting? Both lingually and labially we place the splint. Single splinting, only on the labial surface we place the splint. Composite resin restoration of full coverage crown. There's a crack. Best treatment would be to prepare the tooth and place a full coverage crown so that there is no microscopic movement of the crack fragments. There is no mobility and there is no subsequent damage to the tooth. So best treatment would be a full coverage crown. Question 17. A patient presents with either say type 1 fracture a few months ago with periapical index score of 2. What will be the appropriate treatment option? Okay. Observation and regular follow-up, non-surgical root canal treatment, surgical root canal treatment, extraction and implant placement. Now, periapical index score means it is a score of 1 to 5. 1 means no periapical lesion, then a small periapical lesion, a larger and a greater 1, 2, 3, 4, and 5, like this. Periapical index score. Amount of periapical tissue destruction that has happened is given by periapical index score. 2 means a small lesion, a small periapical lesion. So whenever there is a small periapical lesion, definitely surgical treatments are not done. So we would rule out extraction and surgical. But since there is a periapical lesion, the pulp has become necrotic, observation and regular follow-up would not do. So non-surgical root canal treatment option 2 is the best answer over. So even if you do not know either say classification, the second part of the question is enough to help you answer the question very well. Okay. Because periapical index score 2 means there is a small periapical lesion. It needs to be treated. There's no need of extraction. There's no need of any surgery. Non-surgical root canal treatment would heal the periapical lesion. That is what we do in majority of the situations. Simple non-surgical root canal heals the periapical tissues. Question number 18. The best method to repair type 3 apical transportation of the canal is MTA plug, surgical correction and apical resection, epexification, warm vertical compaction. Now these apical transportations are type 1, type 2 and type 3. Apical transportation means this is a root canal. This is the apical foramen. Due to iatrogenic errors in preparation, there's a minor migration of your apical foramen. From here, it has come here. Type 2 is a more severe form of apical perforation, and type 3 is a most severe type of apical transportation, means from apical foramen was originally here, and what we have done due to inadequate preparation, we have placed the apical foramen over here. Okay, so it is the mild form of apical transportation. This is moderate form of apical transportation, and this is severe form of apical transportation. The question is asking type 3 severe. What are the treatment modalities? In mild type, we have to do cleaning and shaping with larger files, short of working length. Nothing special is required. Okay, we simply do cleaning and shaping with larger files, slightly larger files, short of working length, so that whatever dentinal debris is generated is compacted in front of the instrument and it closes the minor apical transportation. In moderate type, we need apical sealing with a barrier material. It is just like your tooth with open apex. So, which is the most preferred better material? MT, barrier material. We form an MT apical plug. And for severe form, we require surgical correction. We have to expose the site surgically and repair it. So surgical correction is required. So these are the three types of apical transportations or perforations and their respective treatments. Now you can answer it. MT plug is used for type 2, not the answer over here. Surgical correction and apical resection, yes. Apexification, again, form of apical plug, no. Warm vertical compaction, definitely not. Because whenever there's apical transportation, warm vertical compaction would further extrude the gutta percha out of the root canal. Not. What is the answer? Option number 2. Okay. Question number 19. Porcelain veneers are contraindicated teeth with bulbous proximal contours. Okay. Teeth with proximal contours like this. Bulbous proximal contours. Vital teeth. It should be vital teeth. Okay. Are they contraindicated? No, they are not contraindicated in vital teeth. In fact, veneers are done in vital teeth only. Elongated teeth with sufficient tooth structure and endodontically treated teeth. A tooth that is elongated with sufficient tooth structure, we can do veneers. Okay, we do veneers in vital teeth. They are not contraindicated. Endodontically treated teeth and teeth with bulbous proximal contours A and D. We do not prefer to do these veneers because veneers, these are bulbous proximal contacts. Establishment of proximal contacts with the veneers would be difficult in such situations. Okay, and similarly for endodontically treated teeth, there would be difficult bonding. Veneers are bonded, so difficult bonding, so we do not prefer. Although they are not absolutely contraindicated, but looking at the options, they are not preferred. Option A and D. This would be the answer. Option 1. Okay. B and C, we routinely do porcelain laminate veneers. So, based upon options of ruling, relative contraindication, this was the last question for today's session. These were the questions that came in INICET examination 2024, that is May 2024 last year, related to my subject. Okay. With this, I conclude today's session. Thank you very much for being connected with me. Keep on reading. Happy festive time. Enjoy your time and study hard. My best wishes with you all. Thank you so much for being connected.